Welcome everybody, my name is Anne Brockhurst, and as part of my final assessment for Unit NSN 728, this is my presentation entitled Limited Access to Healthcare for Older Rural Australians. So to begin with, how has this become an issue in nursing? So we have an ageing population. In 2016, 15% of the overall population of Australia were aged over 65 years. In our local area, the population aged over 65 years in 2016 was 20%, so this is 5% higher than the national average. This combined with the knowledge that rural Australians have higher levels of disease and injury and shorter lives and with poorer outcomes, which is somewhat attributed to the fact that rural Australians are more likely to be risk takers, to drive without a seatbelt or use faulty machinery, consume a poor diet and smoke tobacco. Also too, in rural areas, there is a lack of primary health care. And a quick Google search of GPs in our area highlighted that none of our local GPs work full-time or are available on weekends. This may also be attributed to the fact that there are lower levels of health literacy and poor use of preventative programs. In rural areas, we see higher rates of poverty, and this may be attributed to the fact that there are higher proportions of Indigenous Australians and Torres Strait Islanders living in rural areas who have lower incomes. As we all know, we're also a big country. There's big distances to travel, and one example of how that can impede health was an example with my daughter, who works on a station near Birdsville, where one of her workmates had to travel 6 hours by car just to get an x-ray on her knee after a horse kicked her. Thankfully, nothing was broken, but that was 6 hours there, 6 hours back. So you can see how somebody with a niggly little abdo pain might put things off, though that niggly little pain might even be a stomach cancer. You don't know until you find out. Our geographical isolation also contributes to the high cost of food and petrol and energy, which leaves little money left over for healthcare. So what's the situation in healthcare? So doctors who are trained in metropolitan areas, where the universities normally are, tend to stay in metropolitan areas. And whilst GPs are more likely to practice in rural areas, their specialist counterparts are not. However, the number of GP proceduralists and those with high skill are declining, so you're less likely to have your GP perform simple procedures such as a skin cancer removal. You're more likely to get referred these days. However, that specialist that you're referred to might be 600 kilometres away, so you'll put off those things until they become a crisis situation. Also too, according to Eckerman and Sheridan in 2016, GPs are less likely to bulk bill in rural areas due to the high costs of running a practice. And there's no competition. They're a business like anybody else, so they can choose to charge what they like. And as for the most important and most utilised health professional in rural Australia, nurses face challenges such as staff shortages. There's no one to replace you for sick leave. There's professional isolation. There's no one there to bounce ideas off. There's little to no availability of professional development and education. And yet we need to possess a wide range of specialised skill not required by nurses in metropolitan areas. Metropolitan nurses tend to be surgical nurses or medical nurses. They don't have that generalist skill base. And yet skilled nurses do need continuing education because there's always something new out there. Yet a loss of specialties in rural areas has led to a de-skilling of nurses. Nurses are not being exposed to learning opportunities from peers. And this affects recruitment, as we've seen in a recent episode at our health service. We advertised for registered nurses with a wide skill set. We got very few nurses who had that skill set. And this affects best practice. Nurses instinctively want to do what's best. They have the best intentions. They don't want to do any harm, but we need support and we need good education. So what are the big issues for our patients? So a lack of primary healthcare services results in people not receiving the intervention when they first become unwell, instead waiting for the issue to become serious or too far gone for treatment. No general practitioner available, so the hospital becomes a pseudo primary healthcare system. People just front up to the hospital. This puts more pressure on the hospital budget. And we know in our own facility, our outpatient department has seen an increase in 21% of presentations on last year. And that has stretched our budget because we've already had our budget cut. So if you don't go to your general practitioner, there's people generally don't have exposure to preventative programs such as bowel cancer screening. So things aren't caught early enough. There's also a reluctance to attend appointments due to travel distance. So if something is pressing, such as it's the middle of mustering season, you're not going to travel 200 kilometres to see a doctor. You're too busy, you've got other things to do. So less access to primary healthcare also results in higher hospitalisation because things are left too late to be handled in the primary care setting. And this sees a need for skilled nurses, but there are less available in the small towns these days. No longer are nurses in rural areas simply farmers' wives who come to town for a job. Nurses these days need university degrees, which are time-consuming and expensive to obtain. So what is the government doing? Well, they put out the National Strategic Framework for Rural and Remote Health in 2012. They spent 3 years putting this document together. However, disappointingly, it's not in use. However, it's interesting to see that the 5 goals put out by the document are those goals advocated for by most rural health professionals. And those are an improvement to access. We need better service models of care. We need appropriately skilled and a well-supported workforce. We need collaborative health service planning and policy development. And most of all, we need strong leadership, governance and transparency and accountability. Queensland Health do have some rural and remote workforce strategies, however, none are specific at nursing, sadly. So what can we do at a local level? Well, if there are no frameworks or no policy, we need to create our own, which are suitable for our diverse rural health context. We need to be innovative. We need to come up with ideas that address our local issues. We need to explore the flexibility in the scope of practice for all health providers and promote a more advanced skill role for our GPs and nurses. Most importantly, we need to unite our team. Currently, our doctors at our health service enjoy financial incentives, free meals and free accommodation. On top of this, the AMA are currently lobbying for an increase to these incentives. Our nurses don't get any incentives at all. We need to band together as we are all frontline health professionals. We need dedicated and quality training pathways. We need professional support. We need flexible work arrangements, some locum relief, family support, and of course some financial incentive also helps. Most importantly, we need to invest in nursing, and we could get some ideas from our fellow states. In New South Wales, they have the Grow Your Own initiative, where undergrads who complete 12 weeks of practical component at a rural facility are then guaranteed employment. They also offered scholarships to help cover the cost of the tertiary fees. In Western Australia, there's a program called Rural Health West, which is supported by the Australian Government, which provides training programs for rural nurses, an ongoing education and a recruitment service. Unfortunately, I was unable to find anything like that here in Queensland. We need to utilise every aspect of our scope of practice and not just the bits that nobody else wants to do. We need to support our advanced nurses. And so nurse practitioners are the most underutilised area of nursing. But some examples where they have worked. In Victoria, a registered nurse was endorsed to become a nurse practitioner through her education. She was then able to provide advanced care to patients and act as a mentor and educator for fellow nurses. In Canada, there's a palliative care support service where nurses go into the home each week and check on those with terminal conditions, refer if needed, provide support, provide community services. That way the patient became well known to the hospital, and if needed, there was a smooth transition to the hospital system for the dying process. In a more recent program, the Chronic Disease Clinic, cited by Bonner, Havas, Tam, Stone, Abel, Barnes and Douglas in 2018. So a nurse practitioner conducted chronic disease clinic where they reviewed all their patients with chronic diseases. They did full review of investigations, had a look at their images and referred where necessary. Did a full health checkup essentially, and apparently it was a very successful program. What can we do currently at our own workplace? We could support an exchange program in order to facilitate networking opportunities. We could look at similar health services such as ours, such as Gympie, and exchange nurses and see how they do things there. We could reintroduce our education days. We used to have dedicated education days at our facility with guest speakers who are innovative, motivating and experts in their fields. We get a lot of money donated through the auxiliary, and I'm sure it's because of the great nursing care we provide. How about we put some of that money towards our workforce? And facilitate rural nurse-specific education with organisations such as Crana Plus and ECT for Health. Some of our staff have already attended workshops conducted by these organisations, and the feedback is very good. If we have good quality education and if we have good support, we can then provide quality healthcare to older rural Australians. We can introduce our own screening programs. We can conduct nurse-led clinics. We can become a referral centre for community supports. We can refer to specialists. We can use our telehealth. And this may help avoid those hospital readmission rates. We can incorporate home visits, make sure things are going successfully at home. We can do health education, health promotion programs such as Stay on Your Feet with our residents. We can improve our communication and information sharing with our GPs. A lot of our GPs in our area only stay for 6 months. We don't even know they're there half the time. We need to foster some relationships. And we need to create programs best suited to our community. In conclusion, nurses are the health profession most represented in rural Australia. We can make access to healthcare easier for older rural Australians. We have some wonderful innovative ideas. We just need a little tweak in policy here and there to make them work. We need support and advocacy from our nurse leaders. Healthcare in rural Australia has its own set of challenges which are unique to those in metropolitan areas. The centralisation of healthcare to metropolitan areas has seen a decrease in the skill level of rural nurses. Let's stop this from happening further. Let's introduce good quality education. Don't stop it yet. We need to nurture our own staff and enable current staff to be equipped with the skills needed to cope with the wide range of patient presentation. Thank you. Hang on, references. 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 More references. Thank you.